So thanks so much again for coming. My name is Aggie Erickson. I'm director of Project ECHO at the Weitzman Institute, and the Weitzman Institute is a research and innovation arm of a large federally qualified health center out of Connecticut. So I will start. The Weitzman Institute, again, is a research and innovation arm that is focused on improving the care and the care delivery on the underserved patient population. And we're doing so focused on research, innovation, and training healthcare professionals, as well as training the next generation. So this is us, our team. And the Weitzman Institute is embedded in a large federally qualified health center, as I mentioned, which is quite important because our work is embedded in 45 years of primary care experience. And the health center started in 1972, providing primary care, medical, dental, behavioral health services, comprehensive services. We serve patients in over 200 locations. 14 of those are larger community health centers, brick and mortars, and then over 60 school-based health centers, as well as homeless shelters, emergency shelters, transitional shelters. So we really aim to serve the underserved wherever they are in our communities. We have three foundational pillars. The first is clinical excellence, second, research and development, and the third one, as I mentioned before, is training the next generation. And we serve about 145,000 patients annually. And this is important also because today's topic is the opioid epidemic, this is one where we need all hands on deck. Everybody is experiencing the challenge of how do we safely and effectively manage pain in primary care. We know that our primary care providers express, and this is across the US, express very low confidence in their ability to manage pain in primary care. And that is also coupled with very little education in medical school that they have received in managing pain. I thought it was about 9 hours up until a few months ago when one of the chief medical officers from Arizona said, how about 0? Well, that's quite challenging to address an epidemic when you received very little and no education in doing so. But how did we get here to where we are right now? 1995 was a quite significant year. That's when the American Pain Society suggested addressing pain as the 5th vital sign. So that's when the president mentioned in his speech first. 1995 is also an important year because that's when the FDA approved OxyContin. And in 1997, all the newspapers and U.S. news was filled with front page articles we have the solution. Why aren't we addressing pain? We should not let Americans suffer from pain because we have this solution. And what everybody was relying on, especially pharma, is this 100-word letter that was published in the New England Journal of Medicine in the 70s, which was really focused on, it's again not even a research, it's just a letter, stating that if you're using opioids for managing chronic pain, there is very, very little likelihood that will lead to addiction. So pharma was using that as a resource and been utilized many, many times. So with that, Joint Commission coming out with really assessing and managing pain. But how can we do it when there is absolutely no tools and resources that are available for the providers besides their prescription pad? So as a large health center, we've been struggling with this. We have many providers. When we were looking for the variation in care and the prescribing of opioids amongst our providers, we've seen some providers had prescribed very little, and then we have providers who prescribed quite a lot. So we were looking for evidence-based models and tools that can support us with reducing that variation in care. So we have learned about Project ECHO in June of 2011 when it was published in the New England Journal of Medicine. Project ECHO is a case-based distance learning where providers, primary care providers, join via video conferencing a session focused, and these are focused in specific conditions, and present their most challenging cases to a multidisciplinary team of specialists. The specialists give advice and guidance on how to manage that specific condition. And there's always a brief didactic, so using video conferencing, case-based learning, brief didactic, and when Dr. Ora published, he utilized this for hepatitis C originally because he was actually two Hep C specialists in New Mexico who were providing Hep C care to uninsured and undocumented patients, and the wait was very often 6 to 9 months, which led to unintended consequences and often death. So he came up with this brilliant but simple idea to use video conferencing. So after he published the study, our chief medical officer got super excited that this is something that we would like to use for many different things, really focused on the hotspots of our communities. So we started with hepatitis C and HIV to improve access to this care in primary care. But as we started with that, our focus was right away on how can we utilize Project ECHO to improve access to chronic pain support. So we wanted this support not only for our providers, but all providers that were struggling with this from across the country. The original model really focused on primary care medical providers, but as we were planning for chronic pain and medication-assisted treatment Project ECHO, we knew that we had to engage the behavioral health providers. We cannot address the opioid epidemic without this integrated approach to really treat the body and the mind at the same time. Especially, you're going to hear later about our research, is that 40% of the patients have psychosocial issues, so we cannot ignore that as a fact. So we have started Project ECHO chronic pain and buprenorphine in January of 2013. There's a couple other ECHOs that we're also offering. Those are complex integrated pediatrics and complex care management. The complex care management is for the nurses, the RNs. As we are having more and more value-based contracting, it's important that we also focus on our nurses, their education, their leadership skills, and how to connect with the community. In terms of our work utilizing Project ECHO for chronic pain and buprenorphine and all the other conditions, we have reached 304 practices in 33 states, plus Puerto Rico and DC. We have supported 775 medical providers, 298 behavioral health providers, and 296 care team members. During these ECHO sessions, over 2,500 complex, challenging cases were presented to the team. What we also learned is, while Project ECHO is really, truly wonderful, and it's really making a difference because it's delivering high-yield approach as well as it's an evidence-based model. What we wanted to, there's actually essentially two things that our providers have to do right now addressing the opioid epidemic is when they have a patient who comes in with new pain, we want to make sure they don't go on a path that is not safe, right? And then how do you stop the bleeding? How do you address those patients that are already on your schedule? And you know that you're going to have a difficult conversation with the patients. And it's even that is quite challenging. We had a session focused on how do you have the difficult conversation with the patient. When patients hearing tapering, it's just like a wall being built right away between the patient and the provider because patients do not want to hear about tapering and getting off. So it's a very challenging situation. So what we have learned is over the years that Project ECHO is wonderful. It builds knowledge over time. It builds provider confidence. It builds provider knowledge. However, those are scheduled, the ECHO sessions usually scheduled twice monthly for an hour and a half each time. We can accommodate about 2 patient cases and a didactic. And it's 2 patient cases because the cases are quite complex and we need to address both the medical, the behavioral health, psychosocial issues of the patients. So when you have a learning community joining with 20, 30, or 50 people, not everybody has a chance to present their cases. While the aim here is that everybody who's on the session is learning by listening to the cases that are being presented by their colleagues. So what we have learned that we wanted to pair these intervention up with other support tools like electronic consultations. So these are asynchronous consultations, which the primary care provider can send a note with their question, attaching any relevant documentation from their EHR. This is HIPAA compliant, and send it to the faculty, and the faculty then responds. And sometimes providers are 80% sure, but they're not 100% sure. So having something in between echo sessions or another tool that they can use is quite wonderful because, and also, you know, when you join echo, we experience provider shyness. Not everybody wants to present cases right away. Although we work with faculty, the faculty has not just have to be knowledgeable and up with the best practices, but also they have to know how to talk to the primary care providers and how to be non-judgmental. This is a learning educational session, so everybody is there to learn. And learning not only from the faculty, but also learning from each other. So having many different tools available for the primary care provider is the way to address the opioid epidemic. So we have, again, Project ECHO builds your knowledge and scope of practice. E-consultation, you have a quick, secure message available for the primary care providers, and the specialist responds back within 48 hours. Then we have websites, and Mandy's going to talk more about the website. That's an additional tool with resources. And then later on, you'll hear from my colleague, Lauren, about the Practice Improvement Collaborative. And just a couple more words about the MAT. We believe that primary care providers should be providing access to medication-assisted treatment in primary care. We know that it can be safely and effectively managed, and we have a lot of primary care providers who are excited and want to do it. They take the training. It's an 8-hour waiver training for MDs, plus 16 hours for APRNs and PAs. But what we have seen, this is really great and fine. Providers do it, get their waiver, but then they start with their first patient and then they stop. There is just tremendous gray areas. There's nobody there to respond to questions. There's nobody there to kind of watch the providers back. This is something new. And providers were also concerned, well, am I going to attract a lot of new patients with opioid addiction to substance use disorder? Well, I think if everybody's looking at their own panel, most providers have plenty of patients who they can support within their own panel. So what we have found that having access to Project ECHO, again, and a team of specialists who are there where you can ask not only clinical questions, but programmatic questions, it increases the uptake and utilization of medication-assisted treatment in primary care. And now I'm going to pass the microphone over to my colleague, Mandy Lamb.
Great, thank you, Augie. And I'm Mandy Lamb, the program manager at the Weitzman Institute for our Project ECHO program, and I'm going to briefly describe sort of the telehealth intervention. So this is just a screenshot of our studio at Weitzman, but as you can see, we have two screens in our studio. We have the faculty on one side, and then we have our participants across the country who join in. This is, again, as Augie mentioned, every 2 weeks we convene, and our faculty is in Arizona. They are currently based at El Rio Health, but not all of them work at El Rio. We have a partnership with them, but they have, between all of them, decades of experience treating pain patients. And this is a sample of, or this is our curriculum for our series. It's a 12-month series, and again, we meet every 2 weeks. And as you can see, we have an array of topics that cover both behavioral health issues, medical issues. We have a pharmacist on the panel. We have someone who's an expert in Chinese medicine. And actually, instead of me talking about it, we'd love to show a short video of one of our sessions. This is a provider who's presenting one of his cases, and this is our faculty providing feedback. So I'm hoping our IT folks can pull that up for us.
I was asked to see a 64-year-old female who had a history of 8 weeks prior to me seeing her. I was carrying a laundry basket down the stairs, fell, hit her right side, her ribs and back, evaluated in the emergency room, had x-rays, no fractures, more probably just a mechanical back problem and contusion, was given a few days of Percocet to take as needed and some Flexeril, 10 milligrams twice a day for any muscle spasm, and asked to follow up with her family doc. She was seen about a week later by her family physician, still had these complaints. She said that the Percocet helped at night take the pain away in the morning. Flexeril's helped. They decided to continue this being more of an acute problem. No additional workup was really recommended. Seen again about 3 to 4 weeks after that. Pain still is there, but it's felt that it will eventually clear. Medications continued, and then it's seen about 2 weeks after that, and person in our practice decided to refer to me. The concern I have, and I hope this is what we can begin to address, is here's a person that now is 8 weeks out of their original injury, not taking a lot of opioid, but certainly continuing to take it every night, probably is going to have some pain issues to deal with in the next several weeks or months. We need to get this anxiety and stress undertaken, but the concern I have is how do we begin to get her off an opioid and not make this person a chronically dependent opioid person?
I mean, we really appreciate you bringing on cases like this, because we would like this to be the How to Prevent Chronic Pain Echo. We hear a lot about people who are very far down the tracks of all kinds of issues, and we've gotten ourselves into all kinds of trouble treating them, but this is not there yet, how not to get into trouble. Kind of the key is the psychosocial screening. How early that's done depends. When I was doing my fellowship in England, the physical therapist would have seen this person first and run her through a tool called the STAR-T. It's the only really validated quick screen to predict future chronicity and problems when you're treating a patient who comes in with back pain, subacute back, acute or subacute. So I'm a big proponent of that sort of screening really early on. In England, they were doing that, and if there was positive, they'd call in the medical people and the behavioral health folks. So at this point, it's time to screen psychologically so that you don't end up treating a patient for psychological issues that are being manifested as pain with pain medicine and all that sort of stuff, so that you don't miss that. And we'll talk a little bit about how to do that. First of all, how you do the screen, and then what you do with the results, assuming they're positive or negative.
I would say 6 sessions of supportive cognitive behavioral therapy to learn pain self-management skills. So she could learn things to help herself, such as relaxation, imagery work, breath work, but also setting limits with family, communication, how to be assertive about your needs, and also encouraging the planning and pacing activities. If she's going to heal, it's a must that she take care of herself. People are saying, oh, well, I have to take care of everyone else. And it's like, well, you're not going to get better, so you can take care of everyone else if you don't take care of yourself now. You know, you might talk with her about chronic pain, and that sometimes that can develop if people don't stop and take care of themselves and allow themselves to heal. But I'm concerned about how much she's trying to do and how realistic she is about how much she should be doing.
Great. So that's just a sampling of one of our case presentations. And as you saw, we had our lead medical provider on the panel providing feedback, as well as our behavioral health specialists. So now I'm going to just move into quickly, as Augie mentioned before, we not only do the telehealth intervention, but we research its impact on the provider and then the patient populations that they serve. This is a recent analysis that some of our research team has done, where we did a qualitative analysis on 66 case presentations in our Project Echo Pain series. And we found that not only are our pain faculty sticking to recommending things in accordance with the CDC best practices, but 40% of the time the feedback that they provided was on psychosocial issues, so beyond what the CDC recommends. So this is an important fact. I'm sure everyone in the room is aware that, these issues are, confounding our problem with serving pain patients, but it's just reiterates the fact that this is an important area that we need to provide guidance on. And I'm going to speak a little bit to our PainNet and our web resources that we provide to our Project Echo pain patients. So we have 2 websites. The first one is PainNet, and this is a repository of all of our Echo series. But in addition, we provide tools and resources to providers to use in between pain sessions. And if you ever participated in any of our Project Echo pain series, you have access to this resource. This is just a sampling of several pages on our PainNet, and again, you can see we have blogs and resources on all different topics, from both medical to Chinese medicine to physical therapy. So our providers in between sessions or even after they finish our curriculum can always go back and utilize these resources. This is a snapshot of our Project Echo buprenorphine. So as Augie mentioned earlier, we not only have a Project Echo pain series, but also a Project Echo buprenorphine, and this is the faculty. And this is a sampling of our didactic curriculum. So we have a core didactic, but we also have topical didactics that we cover throughout the course of the year, and this really comes from our providers who provide feedback to us and say, we really need help treating our, pregnant patients who are suffering from opioid misuse. And we also provide, for our buprenorphine echo, additional resource of, again, similar to PainNet, but a website where we have a repository of information that they can access. And so with that, I'm going to pass it back to Augie to talk about CECN.
So I did mention briefly already that we not only utilize Project Echo, but also electronic consultations. And the way we got to this, how did we start with electronic consultation, is that in 2011, actually going back, is our patient population has very little or no access to specialty care. And when they have access, it's a very, very long wait. And we just know that that is not okay. It's not okay for our patients to wait 6 and 9 months to see a specialist. So in 2011, we started a study on cardiology. Basically, it was a randomized clinical trial working with UConn Health Center. We worked with a cardiologist, and we sent, instead of the consultation going in a traditional way, going to a community-based specialist, it went via e-consultation. We work with all the specialists, the cardiologists, on creating a protocol. So what are the things that you need to have in order to have a good, enough information where you can provide a sound response. So we have a protocol for all our e-consultations, and to make this short, the outcomes was that 69% of the patients did not need a face-to-face visit for cardiology. So from that on, we were looking, how can we utilize e-consultations for different conditions? So now, to this day, we offer 39 different specialties, certainly including chronic pain, neurology, ortho. So what we have learned is, providing access to electronic consultation is, again, another tool for the primary care providers, where the patients don't have to wait, don't have to suffer, and also reduce a lot of headaches for everyone, the patients, the providers, and reducing a lot of costs to the healthcare system, because within 48 business hours, a primary care provider knows that this patient needs to be seen by a specialist or no. And if it does, we hope that with this process, you really eliminate and weed out all those unnecessary visits. So when patients do need to go see face-to-face with a specialist, they don't have to wait that long. And also, specialists have a better appreciation for seeing patients that are, they can really utilize the skills at top of their license versus seeing patients that were totally unnecessary, or having patients that don't show up for the appointments. And we have published on our work also, and actually this is a sample of the pain medicine e-consult. The e-consults for pain is a little bit longer, are a little bit longer than others, because again, these are quite complex and not only focusing the medical, but the behavioral health and the psychosocial aspects as well. So again, when we look at the epidemic, including electronic consultation with Project Echo we believe it's a sound approach. And now we're going to pass the microphone over to Lauren Bifulco. She's going to be talking about our research.
Hi, so as Augie mentioned, I'm Lauren Bifulco. I'm a research associate, and I work with Augie and Mandy at Weitzman Institute Community Health Center, Inc. in Middletown, Connecticut. I'm going to be talking to you a little bit about a pain practice improvement collaborative that we run out of Weitzman Institute as a tool for bringing guideline-informed care recommendations into practice. The purpose of adding a pain practice improvement collaborative or a quality improvement learning collaborative to our existing ECHO sessions is to really engage providers and care teams in the mechanisms that allow the recommendations that providers receive at ECHO to be applied into frontline primary care. We feel that combining ECHO and the Practice Improvement Collaborative really assists with implementing best practices from ECHO by providing basic quality improvement training and encouraging partnerships not only within health centers between providers and care team members or between providers from different departments, but also among providers from various geographic locations that take part in our online collaboratives to share knowledge, share information, and share frustrations and support each other as they try to care for these difficult patient populations. Weitzman's online pain practice improvement and opioid treatment assistance practice improvement is on Moodle, which is a massive open online classroom platform. We provided this information on Moodle as a means of allowing providers and care team members to access quality improvement tools, strategies, methods, information, and forgot where I was going with that, sorry, at ad hoc, whenever they need. So some of the content that we've put onto the Practice Improvement Online MOOC, Massive Open Online Classroom, included a little bit of information about how to use Moodle, a little bit of information on the quality improvement measures that we ask teams engaging in our collaboratives to collect pre and post via chart review, and a bunch of information about tools, methods, and strategies that they can use to form teams at their health centers to actually move guideline-informed recommendations into practice, to identify patients who have chronic pain and who are being prescribed opioids for chronic pain or who are being prescribed buprenorphine for medication-assisted treatment of opioid addiction and dependence in a really systematic way so they can track cohorts of patients. Information about opioid prescribing do's and don'ts, heavily focused on the 2016 CDC guideline recommendations, and some tips and tools on how to document opioid treatment and pain treatment using opioids in their electronic medical record, and a bit of information on how to do functional assessment for patients, the importance of screening for behavioral health, and the importance of educating the patient on opioids. I'll share with you a few results of some of the work that we've done. We like to use Moore's expanded outcomes framework to really get a full picture of what the work that we do with teams engaging in the Practice Improvement Collaborative does for them, for their health centers, and for patients and the community. So we assess participation and satisfaction in ECHO clinics and pain practice improvement collaborative activities. We assess learning, declarative knowledge, so do they know what they're supposed to do when they are visited by a patient who has chronic pain? Procedural knowledge, do they know how to do what they're supposed to do? Competence and self-efficacy, do they feel that they're able to do the things that Bennett Davis and the ECHO faculty at Pain ECHO teach them to do? Performance, this is assessed usually via chart review. Is the provider actually doing the things that they are recommended to do during ECHO and that they feel that they have sufficient self-efficacy to do? And downstream outcomes like patient health and community health. So again, we feel that participating in ECHO increases knowledge, participation in the pain practice improvement changes practice, and the eventual outcome will be to improve patient outcomes. This is definitely an area of focus that we've adopted at Weitzman, being a primary care practice embedded in a federally qualified health center. Our most recent research on this was on a randomized control trial, a comparison between intervention and control groups, intervention providers participating in Project ECHO, control providers not participating in Project ECHO, recently published in Pain Medicine in the October 2017 issue, if anybody would like to check it out. We did find a statistically significant improvement in pain-related knowledge among intervention providers between pre-intervention and post-intervention compared to a control group. So the green bars there show the intervention providers, and the white bar show the control group providers. We also found concurrent changes in how they were actually practicing. So between control and intervention, we found intervention providers were less likely to prescribe any opioid. They prescribed fewer opioids overall. They were more likely to refer to behavioral health, to physical therapy, to pain management, to surgical specialties, and to physical medicine and rehab. Some other preliminary work has also indicated that providers are more likely to document that they've completed a functional assessment with their patients with pain, that they've reassessed pain after the initial pain assessment, that they're referring to behavioral health and patients are actually visiting behavioral health, and that they're less likely to prescribe any opioid after having participated in Project ECHO. So our expanded focus on the quality improvement aspects of providing evidence-based care to patients has been chunked in our online collaborative into two categories: clinical best practices and non-clinical best practices. Our clinical best practices include information on safe opioid prescribing, opioid dosing and co-prescribing, and the importance of integration with behavioral health. And our non-clinical best practice measures, which are assessed by organizations' participation in the collaborative, include categories of panel management, education provided to both clinical staff and patients on guideline-informed care, and use of quality improvement tools. This last part is a unique aspect of the work that we do out of Weitzman Institute. We have a heavy focus on empowering providers and frontline personnel to actually make changes by doing things like assessing who the stakeholders are at their organization, planning and making elevator speeches to demonstrate the importance of this work, engaging in strategic planning, even if you're a frontline medical provider or a receptionist or a medical assistant or a nurse. We want people to be thinking about how they can actually implement the changes that they learn during ECHO in primary care. So this chart, it's a little bit hard to read. The measures on the left show the clinical best practice measures, which were assessed via chart review. The measures on the right in those right three categories show non-clinical best practices that were achieved through participation in the collaborative. All the check marks are a health center that has achieved that aspect of the program after participation in the program. So you see a lot of green, if nothing else, up there, and that indicates that there's been some pretty good uptake of the practices that we recommended during the collaborative, and that health centers are actually able to implement them after participating in Project ECHO Pain, Project ECHO Buprenorphine, and our practice improvement collaboratives. I'll talk a little bit about the buprenorphine prescribing work that we've done at Community Health Center, Inc. We've prescribed buprenorphine since 2007, so that left bar shows the total number of patients who've been prescribed buprenorphine. Agi mentioned that we began Project ECHO in 2013, so a significant proportion of the patients at CHC who have received buprenorphine have been prescribed buprenorphine with the assistance of Project ECHO since 2013. Including 617 patients within the last 6 months. And a published study by the lead buprenorphine prescriber at Community Health Center, Inc., who's also the lead faculty member on Project ECHO, indicated that our buprenorphine retention rates at CHC among providers who are participating in Project ECHO, their patients were as likely to be retained in care as patients who were seen by substance abuse clinics, and it was correlated with patients having received psychiatric medications and patients not using cocaine at baseline. So I'll pass it back to Agi and Mandy to discuss the national impact of our ECHO programs.
Thank you. I'm just going to wrap it up, but with the following is that managing pain in primary care is very challenging and complex. We really need to have a multi-pronged approach to support primary care providers with many different tools available to them in many different ways, so they can utilize them as they need it, when they need it. So again, echo, improve knowledge, e-consultation, respond a quick question. And then the Pain Practice Improvement Collaborative is really important for the practices, because providers learn a lot during echo, but if you don't have a practice and a system that can embed those new knowledge and new learning, then you end up with really brilliant providers, but you're really not able to scale it. So having an infrastructure that can support the implementation of evidence-based best practices is quite important. And this is a snapshot of our national impact on providing pain echo, buprenorphine echo, as well as e-consultations and the pain learning community. And so I summarized it that we need all hands on deck. Thank you so much. And I'm not sure if you take questions now or at the end. At the end, thank you.
So I'm Jay Ostrowski with Behavioral Health Innovation and Adaptive Telehealth. I'm going to be talking more about general app applications. My company is involved in creating a lot of them and working with companies to create them. And then Dr. Campbell's going to talk about some of the research she's been doing in the app she's been helping to create. So my role, Behavioral Health Innovation, is to help people create these apps. So what we find with patients is that they're often have a lot of issues when they're in treatment. My focus obviously is on more the patient side of things and their experience. One of our goals working with some of these national companies I work with is to keep people in treatment long enough to get the results. There's like a lot of 2 to 5 sessions, and then they drop out. So we're looking at apps to help them stay engaged and actually get them into other counseling treatment and get other supports in addition to medication-assisted treatment. So that's been more of our focus, is how do we get people engaged. Another approach we've been taking is working with patients that are maybe they're already addicted, and we're working with them on the substance abuse, or maybe they're just starting out in pain management, and we're trying to intervene early to prevent some of the addictions or catch them along the way with kind of supportive therapy services along the way. So we found just a couple of areas that we focus on. Is one, when we give them a treatment, they often forget what we're telling them because they walk out and they're feeling a little bit better. Maybe they didn't retain it or weren't really focused on it at the beginning. So we want to have them have on their person information that they can reference to remember. So we want to give them some ways to basically direction. Here's what to do next in your treatment plan. So we want to put their treatment plan on their phone and help them have access to that in a HIPAA secure way. As you guys probably know, a lot of apps claim they're HIPAA compliant, but to be HIPAA compliant, you have to be a covered entity, right? So a lot of technology, that's kind of a marketing phrase people use, but they often don't really go through the administrative, technical, and physical controls that are part of the kind of security cloud. So we try to help companies see where there's security holes and fill those holes when they're making an app, or help them find apps that fit those security needs. And then, of course, we need to integrate with their EHR to pull in that treatment plan. So the treatment plans give the patient direction. And then sometimes we need to give them some self-help. Maybe they have trouble with insomnia. I know a lot of the pain patients I take, they have a pain medication they're taking, but it's kind of a stimulant because a lot of this causes drowsiness. And then later on at night, they can't sleep, so they take another medication to help them sleep. And then in the morning, they need more stimulant. So it starts this really bad cycle. So we try to help them with other ways to monitor their sleep. They may have secondary or primary insomnia as part of this. And of course, the gold standard for treating insomnia is cognitive behavioral therapy. So we want to give them some sleep aids and coaching and self-help for that. But also some of the reminders can be relapse prevention, staying away from triggers, more substance abuse treatment programming that could be put in their phone as part of their treatment. And then, of course, reminders on appointments. So how many people have dropouts and don't show for appointments, right? So we have reminders to kind of take away the excuse level, but a lot of people will go to appointments if they are just prompted and they have a reminder on their phone. A lot of people that struggle with substance abuse have struggled with lifestyle management and keeping a job. So having a reminder on their phone really does help them with that lifestyle change and developing new habits. Some of the other approaches we've taken are just kind of operationalizing treatment for their life. We do that in a business. We operationalize, patient retention, or we operationalize collections or our clinical protocols, but we don't think about that in applying treatment to a patient. How's the patient going to create new routines? So we want to have them make sure that they have some kind of programming in their life that helps them keep up with that treatment. And then the final part is engagement. We want to have them use some gamification techniques, and I'll show you just some little brief examples of that. But we want them to have maybe some clever games, some engagement, and that's where we're working with a couple companies now to kind of pilot that and experiment with what would keep people interested in coming back to a treatment app. So there's not a lot of, there's some research out there showing that gamification really is a positive influence on treatment, especially retention, but we really need more research on that front to kind of prove out some of these use cases. But the other part of engagement is to get them engaged with the community. So what are people doing to engage with other people? Addiction is kind of a lonely condition to be in, or disease if you take a disease model. So we want to have them connect with a cohort that can encourage them in between sessions and really lead them towards a recovery lifestyle. So again, we look at the primary focuses we try to do, put into these apps are patient engagement, and then the treatment adherence through their personalized treatment plan, and then communication with their providers, or maybe access to other elements of treatment that I'll get to in a moment. But some of the communication could be instant messaging with a provider that's on call to answer questions or give them encouragement or lead them to resources, or say, do you need to get more help right now to prevent some relapse? Or it could lead to a video visit where we have someone that's starting to slide into a crisis so we can do early intervention. So as you're thinking about adding technology to multiply how you treat opioid use, treat opioid abuse, we wanted to kind of expand the idea a little bit more beyond just the in-person or the televisit that's reimbursed through video. We want to look at that text-based. Now, I wouldn't say that text-based only is the treatment modality, but we are finding that people being able to connect with a provider on short notice, just to get a little encouragement or direction, is a really good thing to keep them engaged or going in treatment and not feel so lonely. And then, of course, the CCBT, the computer-based therapies, are a good adjunct to a lot of the trainings that we do over and over and over again. We can just make them into a video, do them once, do them well, and then have patients see them a lot of times. And then there are lots of different apps that can be used as part of treatment to either as an adjunct to treat depression or anxiety. So we want to think a little bit more broadly about how do we incorporate apps and technology, not just the video visit, but how do we use it part of a kind of a treatment protocol and have it fit the individual needs. One of the things that I encounter often is that one size doesn't fit all, right? Even in this room, we have different professionals that use apps at different rates. And I don't know about you, but I have a lot of apps on my phone I don't use. You have those? It was exciting once, and then we stopped using it because it didn't meet other needs we had, or we just forgot about it. But if you're using it as part of a daily routine, maybe a daily check-in that pops you, how you doing today? And if you're not doing so well, it could lead to other treatment protocols. So if you're thinking about making an app, I want to just point out that there are lots of functionalities that you can tap into, and a lot of it is just dependent on your creativity. What do you want to put in here? What's needed for your community? A lot of people can use location services to geofence around danger areas. So now it's going to start over. I'm going to stop pushing the button. So I have a button addiction that I have to. But you can use a geofencing to geofence around danger areas or within good zones to say, this is a safe or this is a danger place, and have alerts that alert other providers or treatment team or to maybe their sober group or recovery group to help them, stay in a good place. We can have medication reminders to take their medication the same dose at the same time, according to their program. Or a lot of people, though, forget. So if it's a once a week encounter, they might forget to go that once a week. So we can schedule, we can remind them. We can have their sponsor contact. There's a program that we've been working on called Parachute. So we started with panic button, but we thought maybe that didn't have such a positive connotation. It was a big red button too, and then the users were like, that didn't feel too good. So we called it Parachute. So if you're going to crash, we want to crash slowly and come into a smooth landing somewhere. And so with that Parachute idea, we came up with the idea of having a little video of yourself talking to yourself, encouraging you to stay in treatment. Or if you're not in that good place yet where you can do that, you can have your provider or a loved one to remind you of why you're doing treatment, why you should stay motivated and stay engaged. And to me, that's been kind of one of the more fun parts of the project, is to add the personalization of an app at scale. The other part is to have their phone number, their sponsor right there, and remind them what you're supposed to do when you're just starting to feel that tunnel vision, and you really just are craving badly for a fix. So we want to get them help in a community. What do I do? Or allow their community to see that they're not doing well and reach out to them. So there's a lot of things you can do with an app with these new functionalities we have. It's really up to your creativity. There are some apps on the market, like SAMHSA has an app that I would refer to. The problem is there's usually a disconnect between the app and the program, because every program is a little bit different and has different needs, maybe EMR needs, or their population is a little bit different. So I think the work to be done with us is how do you bridge the apps and technology with the local need? The good news is lots of people are doing that. It just takes a little bit of program design and making sure that the data flows in a natural and normal way. And that everybody that's part of that treatment flow is on board with this and feels like this is convenient, this can work with what I'm doing, and it's not a lot of radical change, or it's not disruptive to the process. We usually look for ways that we can create efficiencies. So if we can create an efficiency and help something do a little bit faster or better, or automated what you're already doing, we come out as the hero, creating a new program rather than the one that's getting in the way. One of the things that we find pretty cumbersome is the referral process, even within one organization. So we have automated a lot of the referral process to people to maybe one provider to another. They can select from drop-down lists, type in a few things, and it pull data from an EHR, so not retyping things. And I mean, a lot of EHRs do this, but if you don't have one that refers out to another organization, these can easily be stood up to fit your needs. Or if you're receiving, you can set up a system to receive the referrals in more of an automated fashion with a simple login that you give out to referral sources to make it go into your EMR a little bit easier. Another thing that we found quite helpful is to create locators for treatment centers or for dosages if people are traveling. So that's just one of the use cases that one of our customers are using. My apologies, I've had to take off some of the branding and some of the companies just to stay vendor neutral on these things. But this is one of the more fun projects, and I had to be careful about proprietary information, but I think you'll kind of understand what's going on here. We have a program where patients basically are asked once a day, how you doing? And the app just pops up. And if they're doing well, they have a smiley face, they go on to treatment, to other content. And the program was set up to be very individualized. And this was actually for an EAP customer that's working with very high-level executives in corporations like Exxon and Mobil and very high-level, wealthy companies. But they're asking, how you doing today? And some of these people are in addiction treatment. Some people are not in treatment at all. And but we're finding some early results that we're kind of catching people starting on this downward slide. And the people that are in treatment, we're able to keep them in treatment longer and engaged. If they don't answer their how you're doing, they typically get a text from their treatment provider if they're in treatment. asking them, hey, how you doing? Like maybe a couple hours later, just to check in. Some people want to turn that off. Some people want to have that on. Some people have a court order to stay engaged. And so we've worked out, these algorithms to keep people engaged, and they're pretty fun. If their smiley face is not so good, it'll lead to maybe, depends on what the company needs, but it could be a PHQ-9 or another assessment or some other survey. And the results of that survey might lead to a live instant message session with somebody, not a bot, but a live person that's there, standby, on call, ready to message people. Or if they're still not doing well, they might just start a live video session on demand to help them, stay healthy and happy. Or some of it could lead to, depending on the severity, could lead to an immediate phone call to that person because they're saying they're suicidal or really in trouble. Or it could lead to some self-help. Depends on what the patient wants and what the provider's able to do. So a lot of these programs can be configurable to what you need them to do. They're all just kind of algorithms and databases. This was another program that's very similar that I work with that was working more with health anxiety. And so with health anxiety, patients are not usually into drug abuse, but this is kind of the same kind of system that can be applied to addiction treatment, and I thought it was pretty. So it's nice looking. But your app could fit your brand, your colors, your workflows, your special needs. And again, every program is just a little bit different, so one size doesn't fit all in our experience. I talked about gamification, and we, as humans, a lot of us don't like to admit it, but we like to be rewarded and praised. So we have set these little alerts and little things like, hey, you have a streak, kind of like your Snapchat streaks if you do Snapchat. Or you might get little rewards for that, and they could be just a lot of encouragement and recognition that, hey, you're doing a good job. And then if your peers, it's hard to see from here, but the peer group, if you're part of a peer group, they could also kind of congratulate you on your anniversary. It could be a week, it could be a month, but they've all been there and they encourage each other, and then they start to interact with each other and recommend kind of fun things to do. But I think apps could be more and more gamified to take the principles we use in games and do that. One of the concepts that we're working on right now is kind of gamifying the treatment education process to make it more of like a journey map. One of our customers wants it like a Zelda for treatment. Is Tarek in here? So Zelda and we were talking about Zelda yesterday, and he wants, if you see his advertisements, they look like almost like a little Zelda thing where they have the person climbing the rope and stuff like that. It's kind of fun. So we want to make it a little less clinical, a little more engaging, and again, there are many ways to do that. And again, in the apps, we don't know what people need at certain points, and we find one size doesn't fit all. So in ours, we might have encouragement for some people that need that, direction for some people that need that, or more appointment reminders, or more education, or more connection. So every patient's a little bit different, and they need something a little bit different to facilitate their treatment. So you got to think of what fits these different segments of the population. At a higher level, though, for longevity, we usually start with one small use case and do one use case very, very well. But in the broader perspective, you're going to want to have integration of whatever apps or whatever technology you're using into your clinical workflows. And you may not get paid for the app itself, but the app itself could facilitate people staying in treatment longer, which does pay the bills, or facilitating people showing up to their appointments or doing video appointments. So it's more, to me, a facilitator, more of a glue, if you will, to how to keep people and patients engaged. It's also very good for kind of branding your program and making it feel like there's something tangible that they take with them. And if they have an app on their phone and there's little alerts on it, they're more likely to click those and to find out what's there. There are a couple little things that we do, though, is we turn off, like we advise turning off the notification display, so it just says notification. It doesn't say, hey, I'm an addict, called you, and they want you to call them back or something. It needs to be enough of kind of a deniability for the patient to use this without looking badly. So, yeah. So you want to engage all of the people that are in your company to find out how you can meet their needs with those apps for longevity. So now I'm going to bring up Dr. Campbell to talk about her work. Thank you.
Okay. Good morning, everybody. I'm Amy Campbell. I am on faculty in the Department of Psychiatry at Columbia University in the Division on Substance Use Disorders. And I'm going to take a slightly different approach on digital technologies. Jay gave kind of a nice overview of digital technologies in general and kind of the different areas that they can cover. I'm going to talk a little bit about the development of a specific digital therapeutic and kind of hopefully go from the research to the kind of commercialization of that particular intervention so you can kind of see what it looks like to really do that background research to make sure that something is actually working. As Jay mentioned, there's lots of apps out there and lots that don't have any research at all behind them. So it's really important that we think about the apps or digital therapeutics that we select for our patients. Okay, there we go. Just to mention, I received grants from NIDA and SAMHSA. I'm also a co-investigator on a NIDA-funded small business grant with Pair Therapeutics. And I just mentioned that because I'll talk about them at the end of the presentation, but I have no financial interest in that company. So I'm going to move very quickly through these initial slides. Jay talked a lot about how digital technologies can address some of the traditional treatment barriers to substance abuse treatment. And this is just kind of framed as, what are some of the traditional treatment barriers on the left and how might technology-based solutions help to address those. If folks are interested in my slides at the end, I'm happy to share them. And again, in addition to kind of the solution-oriented kind of positive aspects of technology-based interventions, there's also some hurdles. And again, I won't spend a lot of time there. So digital technologies can address a number of targets. And I'll show you at the end a resource that you can take a look at that's really a database of digital technologies for substance use disorders that have kind of been vetted and include the research that's behind them. And so I'll show that for you guys in case you're interested in looking at some of these on your own. But these are just some of the areas that digital technologies target. When we think about substance use disorder treatment interventions, digital technologies can be used in a number of ways to help us support our patient population. So they can be used as an adjunct to care, really extend that clinician's reach out past kind of the brick and mortar treatment program. They can be used as a replacement for certain components of treatment, so like a psychosocial intervention. They can be used for continuing care, recovery management, and they can also be used as a standalone intervention. So I'm going to talk specifically today about the therapeutic education system, or TES, but I was just going to highlight a few additional treatment interventions that have multiple randomized controlled studies behind them, and so have an evidence base to them, and that includes CBT for CBT, which was developed by Kathy Carroll and colleagues at Yale, as well as SHADE, which was done by Kay Lampkin's group in Australia and targets alcohol, marijuana, and co-occurring depression. And so that's the CBT for CBT site and the SHADE site there. And these are all available on the resource that I'll show you at the end in case you're interested in learning more. So the therapeutic education system was developed in the early 2000s by Warren Bickel, Lisa Marsh, and colleagues. And it was grounded in two science-based substance abuse disorder treatments already available, and two interventions that really share quite a bit of research efficacy and effectiveness. And that's the community reinforcement approach and contingency management. You all might be familiar with both of those, but briefly, CRA is kind of the premise is that drugs compete with delayed pro-social reinforcers. And so CRA promotes skills training to teach, encourage, and increase satisfaction with drug-free sources of reinforcements. And then contingency management, of course, is kind of providing incentives for objective positive behaviors. Typically in treatment, that's abstinence or retention and care. So TES has quite a bit of prior research. It's probably one of the best researched web-based interventions that are available. The 4 studies that up here are primarily TES among buprenorphine or methadone-maintained patients. And basically what these show is that TES is comparable to clinician-delivered CRA and contingency management, that it enhances opioid abstinence rates, and that the combination of CRA and CM benefits over and above just what contingency management can do. So often people feel like, well, it's the incentives, right? It's not the cognitive behavioral skills training, but indeed there's that synergy between the two that are important. These are just a few examples of some of the TES modules. You can see some relapse prevention modules up front, followed by some of those kind of social skills, personal skills training. In its web-based form, those are some of the TES screenshots. You can see there's some video clips in there that model skills behavior. And then I participated and co-led a large effectiveness trial of TES in 10 outpatient substance abuse treatment programs. And this study was conducted within NIDA's Clinical Trials Network. And this was one of the largest randomized controlled trials of a digital therapeutic. So we randomized 500 people to treatment as usual or to treatment as usual plus the TES intervention, and it was a 12-week trial. And just for sake of time, I'll just kind of cut to the chase. It was a positive trial. So those that got the TES in addition to treatment as usual had better abstinence outcomes and were retained in treatment longer. This is just my bona fides here, so you can see that there was data in a chart. And this just shows the retention outcomes with TES on the top, just kind of that survival curve over time, significant difference. So one of the problems that Jay alluded to is that how do you scale up these evidence-based digital therapeutics, right? So we've gone through this long research development phase. We've got this efficacy and effectiveness research behind it. Now how do we get it out to people? And when things originate in kind of an academic or research setting, that's sometimes very difficult. We say, well, you know, here's the data, and who do we hand it off to next? So how do we get this out to the public? And so that's where these public-private partnerships are really, really important in terms of digital therapeutics. And so what happened with TES is that a company, a new kind of technology startup company called Pear Therapeutics acquired TES. They're very interested in creating regulated reimbursable products. So this is kind of a different idea in terms of, we think of these apps as kind of things that will just be added on to treatment. What they're saying, well, let's get regulation behind these things and let's get third-party payers to pay for them. So that's the idea. And basically they'll select interventions that have a lot of good efficacy data behind them. So that's what they did, and they put this through FDA clearance, and it was cleared through the FDA in September of 2017 as the first prescription digital therapeutic. The commercial name for TES is Reset, and so this is the mobile version of TES. And so they have clearance for indications, classifications, special controls, similar to what you would find on any other sort of FDA-cleared device or medication. And this just has a few kind of screenshots of what this kind of revised intervention looks like, and it includes both the patient-facing intervention, the contingency management component, as well as a clinician dashboard so that the clinician and the patient can kind of interact on that platform. What they're doing now for opioid use disorder, given some of the work that we did earlier did not include people with opioid use disorder on a medication. They were all just getting psychosocial treatment, and it didn't work as well because, of course, we know people with opioid use disorders, the first line of defense is MAT. And so now they're putting in this multimodal drug device combination through FDA clearance process currently. So the idea is that this would be a combination package of both buprenorphine and the Reset app based on that prior research that I showed you with TES among buprenorphine and methadone maintained patients. So I'll finish up there. I just wanted to put up this resource, the Center for Technology and Behavioral Health. This is a NIDA-funded center of excellence at Dartmouth. And this is the place that you can kind of go, they have a huge database of digital therapeutics. This is just the screenshot for TES, so it provides a nice overview. It presents, which population this has been used with, what were the outcomes. It provides the actual publications showing the evidence behind each. So I think it's a really nice resource if you're thinking about using one of these. And it also demonstrates whether or not a particular intervention has been commercialized. Another additional resource is a Samsonite blending product. Technology-assisted care for substance use disorders. Again, it provides a number of evidence-based digital therapeutics. So I'll close there and happy to hang around afterwards too if there are any additional questions. Thanks very much.
But one of the top questions I got voted on here was to our panel is, can you please talk more about how to get started with something like this in an organization? Like what steps you took to get where you are? And so our topic is telehealth, and we didn't talk a lot about how to get started in telehealth specifically. And for that, we have telehealth resource centers. I'm part of the Matrix. Here's a consultative partner to help people get started. So it's kind of a big question for a short time. But what I usually recommend is to connect with one of the telehealth resource centers, and I'll be happy to help you out or guide you to the right people in your area to get you started. I would say that the place to start, though, is really defining as narrowly as you can the problem that you're trying to address with your organization and your population. But my question, I think, to the panel would be good, since we have a lot of white experts here, is how to get started in the ECHO program. Can you speak to that, please?
Sure. So if you're interested in a project ECHO, there's actually two ways you can do. One is you can research. There are lots of project ECHOs out there, and see if are there any existing ECHOs that could meet the needs of your population or address your problem. And if you can't find one, would you like to start one? And if you do, then there is we can give you some guidance, or ECHO University in New Mexico can do that as well.
Great. And to stay on time, we do need to wrap up, but there are a lot of resources for you guys. We do have quite a few people doing substance use treatment and abuse treatment through telemedicine and tele-MAT as well. So we're here to help you, guide you to the right resources for that. But thank you for joining me, and please thank our panel for me.